introducing my great colleague and friend Ron Pizzoni, who is a distinguished research scientist here at Arbor Research. And Ron, of course, has been with the DOPPS program since the very, very start, so right back in 1996. Ron's going to moderate this next section on in-center hemodialysis. So Ron, please take it away. Thank you.
Hey, Bruce, good morning, and hello, everyone. It's great to have our spring update meeting again, and a real pleasure to be part of the DOPPS team. We've got a really interesting session this morning, and it's just great to be here. We have 17 countries currently participating in DOPPS 7, as can be seen here. The US and Canada, North America are the 7 countries in Europe, 6 of the GCC countries, and China and Asia. We are going to, we're planning now for DOPPS 8 to start next year. Excuse me. And we also now have a number of data hubs or locations where we're sharing DOPPS data for additional analyses to be carried out, as can be shown here on this slide, in Canada and China and Japan. These are just additional efforts to find ways to have additional research to be done with the DOPPS data. And of course, we're always interested in sharing the data with research groups across the world, really, who have particular projects that they may wish to carry out. And so for any of the folks who are on the line and listening, and they may have a project and where the DOPPS data can be useful, please always consider submitting a proposal that we can evaluate and see if that could be a possibility. And the DOPPS data have also been very helpful for a variety of ancillary studies that where the data have been used over the years, where folks have submitted grant proposals to typically government funding agencies, and then have been funded and have used for those purposes. One that's being used right now is by Dr. Carrie Kavanagh at Vanderbilt in really characterizing health literacy and associated associations with outcomes in hemodialysis patients and PD patients as well. So today we've got several presentations and really interesting talks in this session. And the first one will be given by Bruce, who's has just been so wonderful to work with, and we really appreciate as the scientific leader of DOPPS and our vice president of clinical research at Arbor Research. So Bruce, if you could take it away with in describing worldwide DOPPS and the latest trends and findings, that would be great. Thank you very much.
Well, hello, and thank you again for joining us today. Before we launch into our wonderful program from speakers around the world, I'm going to give a very brief whirlwind tour of the DOPPS latest findings, trends, and opportunities. All right, I will speak about CKD mineral bone disorder and anemia, but start first with an update on key trends in survival, demographics, policy. And this is a great graphic because it shows over time marked improvement in survival on dialysis over the last 20 years. This is in particular in the US in light blue. This graphic is not adjusted for age, but if we did adjust for age, we would see improvements in survival in all 3 regions that I'll highlight here in this talk: the US, Europe, and then Japan. And in fact, adjusted for survival, for age, survival in the US is still lags slightly behind that in Europe. But importantly, and you know, kudos to all for this, The improvement in survival over time, based on our work, appears to be explained in part by improvements in key practices. So use of AV fistula, reduction in excess interdialytic weight gain, improvements in KT4V above 1.2, reduction in phosphorus to less than 5. We're working towards a submission of a manuscript in this regard. But again, speaks to great work done by many to improve care for dialysis patients. At the same time, we're facing the reality of a much larger and rising dialysis population. This is a graphic from the US RDS showing a number of patients on dialysis or transplantation, which has risen in a linear fashion over the last 20 years, now totaling about 780,000. And we anticipate, based on our own projections, around 1 million dialysis patients within the next 10 years. China now about the same number as the US, and Japan in third place at 350,000. Prevalence of dialysis is rising because of underlying demography, as well as longer survival. But because of the longer survival, this is a graph showing dialysis, years on dialysis or vintage, and that has risen over time. We see in the US on the bottom up to over 4 years on average. And in Europe on the left, anywhere from over 4 to just over 6 years on average among patients on dialysis. And in Japan, amazingly, mean number of years on dialysis is now over 9. Lots of work for us to do together with you to sort out ways to optimize care for patients who've been on dialysis at longer vintages. All right, to summarize this section quickly, declining adjusted mortality, and great job all this is partly explained by improvements in care. At the same time, underlying demographics lead to a rising number of dialysis patients, greater ALS frailty vintage for those patients. So lots of work for us to do together as a team. And just to speak quickly to policy, really an exciting time in the US as we have the CMS has new payment models to incentivize delay of CKD progression, greater use of home dialysis and kidney transplant. This is the first major policy update in the last 40 years or so. So lots of anticipation and potential excitement here for the benefit of patients. Moving on to MBD, I'll focus on phosphorus as well as PTH. This is a graphic showing within the 3 regions again over the last 20 years, trends in improvement in phosphorus level in all 3 regions. However, if I remind you that KDIGO asks us to keep to bring phosphorus levels towards normal, and we have a long way to go still. Percent above 5.5 in Europe, actually across the 3 regions ranges from 27 to 40%, and that's 5.5, let alone 4.5. And we have some recent data that may indicate the advantage of moving towards 4.5, published here by Marcelo Lopes in NDT just recently, essentially on the left-hand side, a monotonic associations between phosphate and cardiovascular events. So really the lower the better. And I would note the innovation to this analysis was that rather than looking at a single phosphate level, what we did was look at phosphorus over time, over the course of 6 months, and essentially average levels that are above 5.5 in what we call an area under the curve approach. But again, suggesting the lower the better. And this I'll point out is really in contrast to a recent pragmatic trial called the high-low study here in the US. Folks have done a great job and should be commended for being able to organize such a study, but I am concerned that their higher arm, which is actually greater than 6.5, perhaps is higher than patients should be at, but time will tell. Moving on to PTH, we have seen a rise in PTH levels in both Europe and in particular in the US, such that now 24% of US patients are above 600, roughly equivalent to the upper target that KDIGO recommends. And what's the reason, what's happening on dialysis? So this is a graphic showing PTH over vintage, the first 5 years of dialysis. And here we see, first of all, that PTH levels are very high when patients start dialysis, so that they're coming in undertreated. They achieve some control quickly with vitamin D, but then after that, there's essentially an inexorable rise over time, presumably due to the development of autonomous or tertiary hyperparathyroidism. I'll contrast this though with Japan, where folks are able to maintain stable PTH levels for a long time. And the real question is whether earlier treatment is going to help us maintain better PTH control. Just want to show one other new publication of ours by Dr. Kamaba. He is to be commended. It's really a great publication, recently accepted, showing in terms of understanding why high PTH may be linked to adverse outcomes. Here we see association of higher PTH with progressive subsequent weight loss. And indeed, this makes sense physiologically as we understand that PTH can tend to be a catabolic hormone. So maybe a cause ultimately linking high PTH with adverse outcomes. So to summarize the section on mineral bone disorder, in my opinion, both phosphorus and PTH levels may be too high for many patients. And indeed, we may be able to improve outcomes by better following what I think is actually really appropriate KDIGO guidelines, bringing phosphorus closer to normal range and bringing PTH within the less than 600 range. This, of course, needs additional study, and we look forward to seeing that work moving forward. Looking at anemia then, I'm going to focus on quickly on the incident dialysis population, iron, ferritin, followed by a few comments on HIF-PH inhibitors. All right, I think this is really important. Again, I'm looking here at time since dialysis start, and the key messages here across the three regions, patients really have low hemoglobin levels, on average 9.5 at dialysis start. So there's tremendous undertreatment prior to start of dialysis. Hemoglobin levels rise very quickly after start, and of course that's because people are given a lot of ESA, particularly in the US, but also in Europe and in Japan. And in particular in the US, a ton of IV iron to begin with, actually around 4 grams over the first year, coming down to around, on average, about 2 to 3 grams after 2 years, at 2 years after the start of dialysis. But a lot of iron. And this is a graphic showing ferritin level, trends in ferritin over 20 years. And particularly in the US, we see average ferritins above 800. And what I don't understand, I really like the pivotal trial, which was a wonderful study showing highest level of evidence with excellent outcomes at ferritin, iron dosing to ferritin around 700. However, here in the US, we see many, many patients treated to higher ferritin levels than this. And I don't quite understand that. I think we'd be best off following that excellent top-level guidance from Pivotal. All right, well, pivoting then to HIF-PH inhibitors, really exciting time for us to think a lot about the anemia space. You know, roxadustat was the first HIF-PH inhibitor approved a year and a half ago in China. Japan now has 5 pH inhibitors approved. Chile was third with roxadustat recently approved. Drugs are under review in both the US and in Europe. And now the uptake in hemodialysis, less than 5% to date in Japan DOPPS and in China DOPPS. We're really well positioned to evaluate trends in care as HIF-PH inhibitors come on the market. The uses today, based on discussions, of course, with colleagues in Asia, include, first of all, ease of use, particularly in the non-dialysis setting, but also in home dialysis patients. And then focusing on in-center hemodialysis, in particular in folks considered ESA resistant. At this point, that's considered to be around 10% of patients, though it really does depend on how one chooses to identify ESA resistance. Safety of the class has been really very favorable to date. And of course, establishing longer-term safety will, of course, take time, and we all need to be patient as that occurs. But there are some real opportunities, for example, to personalize care for patients making informed decisions to pursue somewhat higher hemoglobin targets, for example, to lessen fatigue, potentially to smooth the transition over to dialysis, and maybe, as a bit of a holy grail, maybe even to delay the start of dialysis by helping patients to better tolerate advanced non-dialysis CKD. So lots of excitement there. So to summarize, take-home points: epidemiology, mortality on dialysis is improving, in part due to improvements in care. So well done all. We'll stay very busy because we have a rising number of older, frail patients on dialysis. And as noted, a lot of excitement and interest in major reimbursement changes in the US that may lead to more home dialysis, more transplant. In my opinion, both serum phosphorus and serum PTH levels are too high in many dialysis patients. On the anemia front, I highlighted the unmet need to improve care, in particular during the transition period to dialysis, and wonder if HIF-PH inhibitors may be an answer. But a lot more work for everybody to do, and we look forward to continuing to play a part in that along with you all. And thank you very, very much.
Thank you very much, Bruce. What an excellent presentation. Just so many interesting changes over recent years. We'll be asking questions at the end of this DOPPS session. So with that, we will go on to the presentation of Dr. Zhao, providing a presentation on the latest findings from DOPPS China. Thank you very much, Dr. Zhao.
Hello, everyone. My name is Xinju Zhao from Department of Nephrology, Peking University People's Hospital. Many thanks to Dr. Bruce Robinson for inviting me. I'm so honored to have this opportunity to share you this topic, DOPPS China local research updates. First, I'd love to introduce the managing structure. Of course, this study was under the leadership of our research, and NBPIA is the coordinating center in China for this program. And we also have a CRO help company to help us monitoring the data, and we use DOPPS link. We included 3 largest cities in China: Beijing, Shanghai, and Guangzhou. In each city, we randomly selected 15 HD facilities. We have 6 KOLs, and the leading investigator is Professor Zuo Li. Now we joined the DOPPS China Phase 7 study. We have 43 study sites in these 3 cities. And its longitudinal data collection began in mid-2019. For now, we have 1,347 patients enrolled. And this year, we launched a new program about incident patient study. It's occurred across all 43 sites in these 3 large cities. The target enrollment participant number is more than 650 incident in-center HD patients. And the patients can then to repeated PRO capture electronically using patient's technology. The research aims are characterize trajectory of lab variables, assess change in PROs over time during the first year of hemodialysis therapy, and describe outcomes such as hospitalization and mortality rates. The first patient have been enrolled in January of this year. The expected end of this study was next year. I have lived at Ann Arbor, Michigan for a year during 2018 and 2019. And at that time, I visited our research several times. With their help, I have a better understanding of this study and the study structure. So after my returned back to China, I gradually established an analysis team. Our first manuscript have been published on scientific reports, and the name is Baseline Data Reports of the China DOPPS. We use DOPPS 5 data. Although it's descriptive, but it's really of great importance and a great value for understanding the current status and the practice pattern for Chinese hemodialysis patients. I'm so happy it can be published in this journal. If you're interested, please look into more details in this publication. We have more than 7,000 census patients, and the sampled patients number was 1,427. The average age was about 60, and it's male dominant. The dialysis vintage was about 2.5 years. 1/3 of our patients have residual renal function. BMI was larger for patients from Beijing than for patients from the other two cities. And the similar results was found for intradialytic weight loss. We have 1/4 of patients have hemodialysis treatments less than 3 times per week. And the indicators showed that the CKD MBD measurement was not wild. Chronic glomerulonephritis was the main primary cause of ESRD, especially for the younger patients. And for elder patients, we can see hypertension and diabetes contributed a lot. During our analysis for mortality risk factor, we found physical function have associations with clinical outcomes. So we look into this aspect separately, and this paper has been published on kidney disease this March. We use 2 indicators. One is moderate activity limited level. Another is climbing stairs limited level as indicators for physical function. And the patients who report they were limited a lot have older age and a female dominant, longer dialysis vintage, and less proportion of patients have a residual renal function and lower hemoglobin and albumin level. Not surprisingly, we found climbing stairs limited level and moderate activities limited level can predict all-cause mortality. Here is a reference. If we use limited a lot as reference, and we can see patients have better physical function, they have better clinical outcomes. And for first hospitalization is not always significant statistically, but still we can see the trend. We also look into the prevalence and risk factors of hyperkalemia in Chinese HD patients. It's the first relative research in China, but compared with the contents in literature, we found nothing new. So it's have been published more locally. We have 2 manuscripts under submission. One is mortality risk factors. Traditional factors such as age, albumin level, comorbidities such as congestive heart failure, and post-prior risk factors. We also found a new indicator that is blood platelets, and we look into this in detail later. Another one is blood flow rate. We found it's an independent risk factor of mortality. And within the range of our most prescribed BFR, which is about 150 and 350. And in this range, we find a linear-like relationship between BFR and mortality. So we treated BFR as a continuous variable. And for all these 5 Cox models, we can find it's statistically significant. So the conclusion is BFR is an independent risk factor of mortality. And later, we look into platelet counts and mortality. We found thrombocytopenia predicts mortality. And we define thrombocytopenia as the platelet count below the lower normal limits. And we found, yes, it's the association between platelets and clinical outcomes. There are still several ongoing analyses, such as machine learning, white blood cells, pre-dialysis potassium, magnesium, and others. And I want to point out that thrombocytopenia analysis will be the first paper with worldwide data. Lastly, I'd love to introduce our analytic team members. The director is Professor Zhuo, and I'm responsible for this team. And we also include a PhD student, DOPPS, China KOLs, and 1 part-time statistician. We have support and help from our consulting team from our research. Here, I wish to express our deep appreciations to Junhui, Brian, Keith, and Dr. Bruce Robinson. Thanks for your help. And this is all for today's sharing. Thank you.
Thank you very much, Jinju. Boy, you guys have really carried out so much just in this very brief period of these last couple of years, and with such interesting papers coming out from all of your efforts. We'll look forward to discussing that and any comments that attendees may have at the end of this session. But thank you so very much. It's really interesting. So now we'd like to proceed with a presentation by Dr. Marcela Lopes from Arbor Research regarding the utility of a single itch-related question in hemodialysis patients. So Dr. Lopes, I would look forward to your talk. Thank you.
Hello everyone, my name is Marcelo Lopes and it's my pleasure to present at this year's Spring Update meeting. Today I'll talk about the utility of a single itch-related question in the Skindex 10 questionnaire for assessing pruritus and predicting health-related quality of life in hemodialysis patients. This study was directly supported by V4. So pruritus in chronic kidney disease is associated with a broad array of patient outcomes, including poor health-related quality of life, and it's often underreported in hemodialysis patients. Previous DOPPS analysis reported that healthcare providers were not aware that 17% of their patients were nearly always or always bothered by pruritus. In dialysis facilities where 21 to 50% of patients reported having severe pruritus, only 1% of the medical directors estimated this prevalence correctly. However, novel pruritus treatments have led to significant reduction in itch intensity and improved itch-related quality of life using some of the instruments that we used in this study. So in this study, we wanted to create and suggest a simpler approach to pruritus diagnosis, which may improve detection among hemodialysis patients. So we did an analysis that compared asking a single question involving the impact of itch in the previous 4 weeks, to the 10-question Skindex 10 score, which is traditionally used in randomized controlled trials. And we do this comparison by assessing their predictive power to predict quality of life. So there were 17 participating countries from North America, Europe, and the Gulf Cooperation Council. Our sample constituted of 4,940 hemodialysis patients enrolled in DOPPS. The Skindex 10 scores were calculated by asking patients how often they were bothered by itchy skin in the past week. There were 10 questions, and the answer ranges from 0, indicating not at all bothered, and 6, always bothered. These scores would then be summed into a total summary score ranging from 0 to 60. The questionnaire also contains 3 subdomain scores: the disease and its impact on emotional and social functioning. The itch-related single question was derived from the KDQOL 36 and asks, during the past 4 weeks, to what extent were you bothered by itchy skin? And the response options included not at all, somewhat, moderately, very much, or extremely. And the itch-related measures, they were collected concurrently with the quality of life measures. And we use here the physical and mental component summary scores derived from the SF-12. And for the model comparison, we will use the prediction power indicated by the respective R-squares from each model. Here we show the patient characteristics by categories of the single question. Characteristics are pretty similar across the categories, especially I want to point out that the MBD markers here, PTH, phosphorus, and calcium, did not vary across categories. But diabetes had a 13-point difference from those that were extremely bothered, 51%, compared to the 38% from the not at all bothered by itchy skin. So there was a direct association with diabetes and no association with most of the categories, especially I want to point out the MBD markers. Here, the distribution of categories of this single question and the Skindex 10. So most patients with the single question answered that they were at least somewhat bothered by itchy skin. So 63% of patients had an itch by the single question. This was different from the Skindex 10, which showed for that 45% of patients had at least 1 point in this questionnaire. And there are some country variations that you can notice by the difference in the categories across countries. Here we show the relationship between the single question and the Skindex 10 score. There's a strong correlation between them, indicated by a Spearman's rule of 0.72. When we look at the total Skindex 10 score and the single question. But there was also strong correlations between the Skindex 10 score domains with the single question. The disease domain has also 0.72, social domain 0.62, and emotional domain 0.7. And here in this box plots, you can see that the x-axis indicates the itchy skin single question categories, and then in the y-axis, the distribution of the Skindex 10 scores. And you can see as there is a direct positive association between them. So when you go up in terms of the itchy skin categories, so do the Skindex 10 scores. So you can clearly see this direct positive association. Here we show the mean and 95% confidence interval of quality of life scores, so PCS and MCS scores that were generated from linear models that included the single question categories and also the Skindex 10 as predictors. So you can see here that for the single question categories, as the patient is increasingly more bothered by itchy skin, the quality of life scores get worse. And that goes for both PCS and MCS. And you can see that for each 10-point higher Skindex 10 score, you're going to have a negative both PCS and MCS scores as well. In terms of prediction power for health-related quality of life, so we have models both with a single question and with the Skindex 10 scores, and from these models we have the R squares, which indicates the prediction power. The higher R squared, the better prediction power. So for PCS, the single question had nearly double the value of the R squared. So there was a greater prediction power for the single question in terms of the physical component summary of quality of life. But for the mental component summary, this MCS, you can see that they're pretty similar. So we can say that the single question was at least as predictive as the Skindex 10 scores when estimating quality of life. So the main findings of this study, there was a high prevalence of pruritus across a sample of patients on hemodialysis. 63% referred being bothered by pruritus by a single question, and 45% when considered the Skindex 10 score. There's a strong correlation between the two instruments. Here we use the Spearman's rule of 0.72, and the single question also correlated well with the Skindex 10 domains. Both questionnaires were associated with poor quality of life, and the single question had a greater prediction power for PCS. Both questionnaires had a similar prediction power for MCS. A simpler approach to detect pruritus, as we did by asking a single question of how much a patient was bothered in the past month, is at least as predictive, if not more, of key health-related quality of life measures as a more elaborate approach using a 10-question instrument such as the Skindex 10. In daily clinical practice, if you want to incorporate this approach to a routine, utilizing one simple question about the extent patients are bothered by itchy skin can be a feasible and efficient way for routine assessment of pruritus. Identifying pruritus will also help risk assessment for quality of life, possibly mortality, although we did not analyze in this study, and may aid in guidance of therapy with the novel treatments that are coming. And also, we know that there is an association with depression, so this could be an important way to assess that. Thank you.
Thank you very much, Marcelo. This is such a interesting presentation, that there are so many patients who are affected by pruritus, and it is such a difficult symptom to deal with, and to have this kind of research to show what the benefit of and the utility of a single question can be in assessing that in patients is I think really informative and helpful for the community, and for further research efforts as well in looking at pruritus in dialysis patients. So thank you so very much. Now we will go on to our final talk in this session, which is by Dr. Erin Flanagan from Tufts University regarding ultrafiltration rate and mortality among hemodialysis patients. So Erin, thank you very much for giving this presentation today.
My name is Erin Flanagan. I'm a clinical research fellow in the Division of Nephrology at Tufts Medical Center, and I'm excited to talk about a project titled Ultrafiltration Rate and Mortality in DOPPS, which I'm working on in collaboration with several others, notably Fritz Port, Marcelo Lopez, Eric Young, and Keith McCullough at Arbor, and Dan Weiner here at Tufts. So the fluid status of a typical patient on hemodialysis cycles over time. There's a gradual accumulation of fluid described by the intradialytic weight gain. That fluid is removed quickly during hemodialysis, which is reflected in the intradialytic weight loss. And over the long interval, the intradialytic weight gain is usually higher. The ultrafiltration rate is then calculated as the intradialytic weight loss divided by the treatment time and is typically normalized to a metric of patient size, most commonly weight. The association between the ultrafiltration rate and mortality has been described in several other observational studies. Rajiv Saran, along with Fritz Port and Eric Young, looked at 22,000 patients in phases 1 and 2 of DOPPS and found a somewhat weak association between a UFR of greater than 10 and a risk of both intradialytic hypotension and mortality in adjusted models. This prospective cohort study in Italy found a much stronger linear association between mean UFR and 5-year mortality in a small group of patients. Magdalene Asselman and Jennifer Flythe examined over 100,000 patients in a single large dialysis organization in the United States and found increased adjusted risk of mortality at cutoffs of UFR cutoffs of 10 and 13. Jennifer Flythe's group also studied about 1,800 patients in the HEMO trial and found a strong increased risk of mortality above a threshold of 13 compared to below 10 after adjustment. In a spline analysis, the risk of both cardiovascular and all-cause mortality associated with UFR seemed to increase sharply at around 10. The Asselman and Flythe paper also looked at the association of UFR and mortality stratified by weight, BMI, and BSA. They found that the association between UFR and mortality was strongest among patients with higher body weights and at higher BMI, while the magnitude of association was similar across strata of body surface area. No formal interaction analysis was done, but the authors concluded that the actual effect size difference was not large between groups and that normalization of UFR to body weight was reasonable. So the aims of the current study are to examine the relationship between UFR and mortality in a large international and nationally representative cohort of dialysis patients. And we'd like to see if we can reproduce the results from prior observational studies, paying attention to the UFR cutoffs of 10 and 13. Secondly, we aim to examine whether the relationship differs by DOPPS region and whether it differs by body size. So our study population includes over 47,000 adult hemodialysis patients from DOPPS phases 4 through 6, which collectively ran from 2009 to 2018. We're looking at UFR averaged over 3 dialysis sessions during a week, occurring within the 4-month DOPPS data collection interval. Our outcome is all-cause mortality. The median follow-up was 1.3 years, and we're modeling the risk of mortality using adjusted Cox proportional hazards models. So this graph shows the distribution of UFR categories by DOPPS region. The main regions are Europe, Japan, other countries listed here, and the United States. In Europe, ultrafiltration rates above 13 are rare, but in Japan and the United States, they're more common. Over half of patients in Europe had a UFR of less than 7, while less than a fifth of Japanese patients did. Keep in mind the number of patients to see the relative contribution to the overall population. Roughly 2/3 came from the United States. In addition to differences in UFR, Japanese patients tended to weigh less, have a lower KT over V, and a longer average treatment time. And patients from the United States tended to weigh more, had shorter treatment times, experienced greater intradialytic weight loss, and were more likely to have diabetes. So looking at patients' characteristics stratified by UFR category, you can see that patients with higher UFR tended to be younger, they had a longer dialysis vintage, they tended to weigh less, but there were not appreciable differences in their comorbidities. Then looking at dialysis-related factors, we see that patients with higher UFR were less likely to have residual kidney function. They had shorter treatment time and higher intradialytic weight loss, as we would expect given the way that UFR is calculated. Notably, there were no apparent differences in serum albumin or KT over V. So here are the Cox models looking at the risk of mortality over the observation period, adjusting for several covariates. Model 1 adjusts for DOPPS region, phase, dialysis vintage, age, and sex. And here we see that compared to a reference category of 7 to less than 10, a UFR of 10 to 13, 13 to 15, and 15 and over was associated with greater mortality. Model 2 adjusts for a much broader host of patient characteristics seen here. And using this model, the strength of the association is attenuated, but the pattern is similar. And model 3 adds intradialytic weight loss, which is the numerator component of UFR. And we still see residual association, suggesting that it's not just ultrafiltration volume, but also treatment time and patient weight contributing to the effect. Looking at the association stratified by region, you can see that there's some difference in the point estimates of mortality risk between regions. In the United States, the association with mortality becomes stronger as UFR increases. In Japan, there's a higher risk at a threshold UFR of 10 and an apparent increased risk at a low UFR. In Europe, the pattern's more flat across UFR categories. In other regions, the estimates vary quite a bit. Potentially, these findings are due to the low number of patients in each category. Remember that there are very few patients in Europe or other countries that have a UFR of greater than 13, and very few Japanese patients have a UFR of less than 7. There may be residual confounding owing to either patient factors or dialysis practices not captured in our model, and interaction analysis failed to show a difference between groups. Now stratifying by weight, we see that patients at greater weights had a stronger association between high UFR and mortality. Patients weighing less than 52 kilograms had a weaker association between UFR and mortality, and a lower UFR seemed to be more deleterious. This may reflect a different phenotype of patient with poor appetite, failure to thrive, which may not be fully accounted for in our model, which we use albumin, creatinine, phosphorus, potassium, and BMI. Overall, these data suggest that a single UFR cutoff will affect patients differently according to weight. It could also mean that there are better ways to normalize UFR than to body weight in kilograms. In stratifying by BMI, we saw a similar pattern. So we did not find evidence of a difference in association between categories of albumin. And when we stratified by treatment time, we found that in the higher UFR categories, there was a stronger association with mortality in those with a treatment time of 4 or more hours. A higher UFR at a longer treatment time equates to a larger ultrafiltration volume. So patients with a treatment time of over 4 hours and a UFR greater than 15 are those with very high intradialytic weight gain, which may reflect dietary non-adherence. And of course, there's the potential that there's confounding by other non-adherents in this group. So the study has several strengths. Firstly, while previous studies looked at a small number of patients or those belonging to a single dialysis organization, DOPPS is an international cohort with nationally representative samples. And it looks at data through 2018, reflecting more up-to-date practice patterns. We're also able to control for residual kidney function. Major limitation is that this is an observational study, and as such, it's prone to unmeasured confounding, whether through body composition or cardiac factors. Also, we did not know the cause of death, so we couldn't assess cardiovascular mortality. So in conclusion, a higher mean ultrafiltration rate is associated with an increased risk of mortality in DOPPS. We did not find a difference in this association across DOPPS regions, despite differences in patient characteristics and practice patterns. However, patients with a higher weight or BMI had greater mortality risk from higher ultrafiltration rates, suggesting that a one-size-fits-all approach to UFR may not lead to better outcomes. Thank you.
Erin, thank you very much for such an excellent presentation. I was wondering if any of the speakers are on the line right now, and we do have a number of questions from panelists. Hi, Dr. Zhao, so good to see you, and Marcelo, and Bruce, and Keith McCullough is here as well, and Roberto as well. Jinju, there were several different questions, and one of the questions is, what has been the experience with HIF-PHI inhibitors to date in China? Is a question from one of our panelists.
Okay, thank you, Dr. Tennyson. As you know, HIF-PHI is commercially available at the end of 2019, and the price has been lowered to an acceptable level at the very beginning of 2019. And so we have 3 years experiences using this medicine. And before that, our center joined the phase 3 trial of Roxtec, this HIF-PHI. So now myself, I have treated with hundreds of patients with HIF-PHI, and most of them, this drug is well tolerated by the patient. And I think for now, we have about a half of non-dialysis dependent patients and 1/3 to a half of PD patients, and a small proportion of HD patients were on this drug. Because as we can see the advantages of this drug for NDD patients and PD patients, because it's the oral, they can take orally, and for HD patients, because they are used to the ESA, and also nevertheless they have to go to HD center 3 times a week, and they are reluctant to change for this drug. I think for most of our patients, the correcting anemia effect is good. But for some patients, like patients with very low hemoglobin level, and they may not respond so well after transfusion and other measures, and then they can respond to this drug. And even for patients with liver cirrhosis, they can respond well with this drug. And we can see the average after they have this drug, I think about 1 or 2 weeks, their hemoglobin will increase 1 to 2 grams per deciliter. And the effect is good. And we still don't know if patients, like for NDD patients, if because they don't have fistula, if the target hemoglobin level should be a little higher than HD patients, because for HD patients, the target level is around 11 to 12 grams per deciliter and no more than 13. I don't know if for NDD or PD patients, if the higher the better. We don't know that. And that's my experience. Thank you.
Well, thank you so much, Dr. Zhao. In that regard, it's great to hear of your experiences where you've been able to, have to use HIF-PHIs now for quite some time, and this is just so helpful to hear of your personal experiences there, and the use as in ND-CKD and PD patients, where it's where it's much more it's easier than to administrate as well. I also had one other question here. It's interesting that about 20% of patients receive hemodialysis less than 3 times a week in China. And what are some of the reasons why patients receive HD less than 3 times a week? Are they starting earlier and maybe they don't need it's not perceived to need maybe thrice weekly dialysis, and is that something that is seen more earlier on when patients come on to dialysis, or just wondering in that regard?
Thank you for the question. I think just the opposite, not earlier but later, because the average GFR for Chinese patients to when initiating dialysis, it's around 5 to 7 milliliter. Yeah. So because we are in a developed country, so no, it's not earlier. But as you can see, quite our patients they have residual renal function. This is one possibility, for this reason. And another is, of course, the reimbursement policy. And for now, even in some province like Shanxi, which in the Middle East of China, most of their patients, they get a reimbursement for like 5 times per 2 weeks. Yeah, but not 3 times a week. They can't do that. So I think it's both with the patient's characteristics and the reimbursement policy. And also, as you can see, the adherence to the doctors, I think in China, yeah, they are a little better, yeah, than patients in your country, I think. Yeah. So that means the interdialytic weight gain may not so many, so they can tolerate with less HD treatment.
I see. Yeah. Well, thank you very much. That's really interesting. Yeah. Thanks for those insights. We also have a question for Dr. Lopes, for Marcelo, and the question is, in your experience, what is the impact of dialysis modality, HDF, versus hemodialysis, and as well as residual renal function on pruritus?
That's an interesting question, Ron. From the literature, dialysis dose and adequacy don't really associate with pruritus, and also MBD markers as we would expect. Residual renal function in also patients that are non-dialysis dependent CKD, they tend to have less been bothered by itchy skin. Although there's also the issues, are we detecting the cases as well as we should? So I think this kind of exploratory analysis that we did just to get a sense of prevalence and using different tools to make that detection, I think this will help in moving things forward.
Yeah. Yep. Yeah, that's a good point. Yeah. Thank you, Marcelo. We have a question here for Dr. Flanagan, and I don't know, Keith, are you responding in this regard? Anyhow, the subgroup analyses and conclusions from your work are really informative, and also the consideration that that maybe rather than one size fits all, that consideration really should be given for a variety of patient characteristics. And I just found the subgroup analyses and conclusions just so informative. The question really is, how was it decided to focus on those particular variables for the subgroup analyses? And for instance, did you look at any others? For instance, were any differences seen for different levels of residual kidney function or for particular cardiovascular diseases, whether UFR, whether the interaction is stronger in that case?
So hi, I'm Keith McCullough. Dr. Flanagan wasn't able to attend in person and answer these questions, but I worked on the project. And unfortunately, we did not look, it had not yet looked into interactions with residual renal function or cardiovascular disease. Sounds like we should. We're focused a little bit more on the body weight. I understand that there's another question about the interaction with the body weight and whether that represented a new finding. And it is consistent with what the data shown in Flight et al. I mean, the confidence intervals all overlap. And I don't know whether their interpretation of, or their conclusion that there should be a single limit was driven in part by practical matters. Not having, the more complicated you make a policy or a recommendation or a guideline, the tougher it is for people to follow it. We are, I think, pushing a little bit towards a less of, as you say, a one-size-fits-all threshold based on the strength of the differences in the associations that we're seeing in different populations. And this might be in part because we are an international study with a wider variety of patients that we're looking at than the Flight study used. But yes, we should look at the residual renal function and cardiovascular interactions as well. Thank you.
Thank you very much, Keith. Yeah. Well, we could spend easily a half an hour asking many more questions. Unfortunately, time is telling us that we have to move forward with our next session. But I just want to thank all of the speakers for such excellent presentations today. So thank you so very, very much. Yeah, so now we would like to present on our PDOPPS study, and have the great pleasure of this session being moderated by Dr. Simon Davies from Keele University in Stoke-on-Trent in the UK. And Simon has been such a great colleague to work with over the years since the beginning of PDOPPS, and was so instrumental in helping to forge the partnership between of PDOPPS with the International Society of Peritoneal Dialysis, ISPD, and also as co-chair of our PDOPPS steering committee. And Simon, it's just been wonderful having the chance to work with you during this time. And so I thank you so much for moderating this session today. I don't know if there are a couple of slides or not, that overview slides here as well, and so this just shows the currently the countries participating in PDOPPS phase 2, a total of 6 countries, and including Japan, South Korea, Thailand, the UK, Canada, and the US. And we're planning a transition to PDOPPS phase 3 to begin next year, and also a US PD practice monitor, which will be launching in July in the United States. So a website that will provide trends in all kinds of different measures in peritoneal dialysis patients in the US, and that will be launching in July, and we'll have announcements about that forthcoming. And other than that, and maybe I will just sign off here, Simon, and thank you again so much for moderating this session.
Many thanks, Ron, for the kind introduction and for the opportunity to moderate this session. I think we're pretty short on time, so I probably think we should move directly to the first speaker. I think the slide that's just currently showing is something we can skip. So it's there are 3 talks in this session, looking at some really new data and analyses being done by the PDOPPS groups. And my pleasure is to introduce the first speaker, who's actually a colleague of mine here at Keele University, Mark Lambie, and he's going to talk to us about international differences in PD time on therapy and related outcomes. Thank you, Mark.
Hello, I'm Mark Lambie from Stoke-on-Trent in the UK, and I'm going to discuss some of the results we've had looking at transfer team analysis, which is the primary outcome for PDOPPS. It's also going to look at mortality as another outcome. So I need to acknowledge the funding before I carry on. So it has obviously had a huge number of funders over the years to support the huge study it's become. So just my disclosures there. So transfer team analysis and death are 2 of the most important adverse outcomes for peritoneal dialysis patients. So they are considered by patients, caregivers and clinicians to be 2 of the top 5 research priorities. So clearly validating the idea that they are the most important things to look at. So the aim of this study was to evaluate international variation in these 2 outcomes and the impact of these outcomes on time on therapy, as well as patient level and practice pattern determinants of those outcomes across the 7 countries participating in PDOPPS. So in terms of the methods, observational cohort, so a very large study of 7,000 patients, so far and away the largest study involving peritoneal dialysis patients. Proportional hazards models with patient case mix adjustments as detailed. So looking at the patient characteristics, I think it's worth noting that Thailand has a PD first policy and has a relatively newly established program compared to the other countries. And possibly as a result of that, the average age in Thailand is a bit younger at 56 years. This contrasts with Japan, which has the oldest age at 64, with other countries somewhere in between. Again, also possibly as a result of the PD first policy, it's got a low residual renal function average with only ½ litre as a median value compared to the UK, which is the largest at 1¼ litres. Again, the other countries are somewhere in between, mostly coming in just under 1 litre. Transplant waiting list referrals are another area where there are substantial differences. So Japan and Thailand, well known as not having a well-established transplant program. It's not a large program there, so only 15 and 24% of their patients referred for transplantation. And in the UK, it has the highest rate at 62%, and again, the other countries coming just behind that. It's also worth looking at differences at the facility level. So Thailand would appear to have the largest facilities, other countries typically more like 50, or Japan and the US down at 30. One area that I do think is definitely worth highlighting is the use of strong bags, and this appears to be a mostly US-based phenomenon. So in the US, over 80% of their facilities have more than 20% of their patients using a strong bag, whereas this is not really the practice in other countries at all. And the UK really does avoid strong bags quite markedly. The US also appears to have the greatest adherence to the idea that KTVs need to be above 1.7 as well. But I also just wanted to highlight the routine multidisciplinary review. So this clearly does vary across all countries within the country, and that will become relevant later on. So just in terms of describing the outcomes, you can see that Japan here has hemodialysis transfer rate in grey. Japan also has the practice that other countries don't of using the hybrid therapy. Death is shown here in black, and then transplantation in light grey at the top. So just looking roughly at the comparisons, you can see that Thailand would appear to have a fairly low rate of hemodialysis transfer, and Japan probably also has a fairly low rate, just in terms of raw outcomes, unadjusted. Death would appear to be the biggest, have the highest rate in Thailand, other countries more equivalent, and then transplantation very different, with Thailand and Japan having a very low rate, US slightly higher, Canada slightly higher again, Australia and New Zealand slightly higher again, and the UK coming in as having the largest rate. All these differences do mean there are significant differences in time on therapy. So Japan has the longest time with a median of 3.5 years, Thailand having 2.9 years, the US and Canada coming in slightly less at 2.3 years, Australia and New Zealand down at 2.1, and in the UK, mostly driven by this large transplantation rate, only 1.7 years on PD. So that's all unadjusted, but looking at the adjusted things, so this is the bottom plot shown here. This is looking at death or HD combined, but these estimates are really just a composite of the individual components of HD transfer and death. So you can see that when it comes to hemodialysis transfer, particularly after you've adjusted for patient case mix, there aren't really much differences in the rate of hemodialysis transfer between countries compared to the US, with the exception of Thailand. Presumably this is as a result of its PD first policy and not having so much in the way of a hemodialysis facility, but it really does have a much lower rate of transfer to hemodialysis there. And surprisingly for me, actually, the differences are much greater when you've adjusted for patient case mix in death. So it's pretty well established that Japan has a low risk of death in the dialysis population, but after adjusting for patient case mix relative to the US, you can see that Australia, New Zealand and Canada both also have a lower risk of death. UK possibly slightly lower, but there's not a lot of confidence in the ability to say that, with confidence bars also crossing no significant difference relative to the US. Thailand, as I said before, had a high unadjusted rate of death. This does appear to be primarily due to patient case mix, in that the estimate relative to the US becomes indistinguishable. So that's looking at international differences, just looking at the patient and facility factors now. So again, this is looking at the composite, but so it's really the HD transfer and death that we're looking at here. So you can see that there are, as you would expect, significant differences with these individual components. So age obviously significantly increases the risk of death, as does male gender. BMI has an association, comorbidities. If you look at the estimates for HD transfer, I'd say on the whole, these effect estimates are much less marked. So the effect estimates are much smaller. There doesn't appear to be any meaningful risk with age. Male gender does have an increased risk of HD transfer, but again, it's not a big effect. BMI does appear to have one of the few ones where it does really have an effect, with a BMI of over 30 definitely having an increased risk of HD transfer, and having a low BMI having a lower risk. Ethnicity can't really assess other than the US white population, and there was no obvious impact there. Comorbidities not obviously having a great association with outcome, although possibly slightly higher risks for diabetes and psychiatric disorders. Residual renal function is slightly protective. It's not a big effect because it's per litre there, but it is visible. Albumin, as might be expected, is a significant adverse, has a significant association there. Looking at the facilities, broadly speaking, again, there are not huge differences between the different practices. The one area where there is a clear difference is HD transfer with routine multidisciplinary review, and the risk is reduced by just over 10% when you have a unit that practices this. Otherwise, there's not a great impact. There's a suggestion that there's an increase in mortality with strong bags, but it's not a lot of confidence in that. And there's a suggestion that increasing the strong bags might slightly reduce the risk of HT transfer, but again, there's not really any confidence in being able to say that either. So in conclusion, I think we could say there are modest regional differences in hemodialysis transfer risk. There are substantial differences in mortality risk when patient characteristics are taken into account. PD patients in Thailand have a high absolute mortality risk due to patient characteristics, but a low risk of HT transfer. Japanese patients have a low mortality risk, and the US patients do have a higher mortality risk than Australia, New Zealand, Canada, and Japan. These outcomes do drive some differences in overall time on therapy, but the marked differences in overall time on therapy we found were mostly driven by large differences in transplantation. And I will finish there. Thank you.
You're muted, Simon.
Simon, you're muted, I believe.
People keep unchanging it. Okay. Am I still muted?
I can hear you now. Thank you.
Okay, I unmuted myself and then it got muted again, I think. So I'm just going to introduce Tansak Kanabutch, who is going to talk about PD in Thailand. We've already had an introduction to that from Mark in terms of basic outcomes. We're now going to hear about the results of the PD First policy and lessons from PDOPPS. Thank you.
Ladies and gentlemen, thank the organizing committee giving me a chance to share our experience. Also thank Simon for your kind introduction. Today I will cover 4 issues, including Thailand PD First policy practice for those who are new to my country healthcare policy, followed by patient demographics, patient outcome, and finally future goals and how to achieve. In Thailand, a country with PD First policy, CPD is the first line modality unless patients are not suitable for PD because of PD contraindication or history of technique failure. Such patients can go to HD without additional cost. Patients who are medically suitable for PD can decline PD and choose HD as the first line treatment, but they have to fully self-support for disease-related costs. Kidney medication, including PD bags, ESA, iron supplements, are fully supported by the policy. PD bags are only provided as standard glucose bed. 2-liter manual bags are capped at 5 bags daily. APD can be reimbursed by the policy for an alternative modality in patients with type 1 UF failure. With intense effort over the last decade, the policy faces many challenges, including PD logistic problems in sub-district and community areas, and unmatched HD support. Until now, the number of cumulative PD cases is 55,000, with 26,000 active PD cases, increasing tenfold compared to the pre-existing era, while more than 150 new PD centers have been operated in the last decade. PD penetration is now 31% compared with less than 10% prior to 2008. This slide shows PD facility characteristic. Thai PD facility are large with an average of 100 PD patients per facility with burgeoning workload of medical staffs. Physician to patient ratio is 87 and PD nurse to patient ratio is 70:1. This slide demonstrates PD patient characteristic. Because of the policy, Thai patient has the youngest age of 56, lowest BMI of 22.7, consume lowest APD. Half of Thai patients relies on caregiver reflecting poor functional status with serum albumin of 3.1 and hemoglobin of 10.3, potassium of 3.7. Thai patient had lowest urine output, suggesting that late referral is a major problem in my country. This concern is supported by 1/3 of the patient had an urgent start PD. More than half start dialysis with temp HD. 80% of the patient starts with full dose PD initiation without an incremental strategies. Let's move to PD outcomes. I'm going to start with peritonitis. Peritonitis is the leading cause of tachyphylaxia and death in Thai PD patients. Crude peritonitis rate was 0.39 episodes per year. However, the rate is comparable with the other PDOP participating countries. Only 18% of the facility failed to achieve the ISP guideline 2016 targeting of fewer than 0.5 episodes per year. However, the range of the rate is high, from 0.12 to 0.68. This high range is an exciting result because it not only emphasizes the center effect on PD outcome as demonstrated by the Australian group, but also warrants further exploration the causes, barriers, and enablers of national PD quality improvement in the near future. Unfortunately, Thailand ranks top in terms of peritonitis-related death and relapse peritonitis, and ranks bottom of peritonitis-related HD transfer, reflecting death without HD transfer. We are now dig deep in detail why is the death without transfer. One of our postulations is related to high culture negative peritonitis rate. This slide shows causative organism by country. This is notably high culture negative peritonitis rate in Thailand, 0.11 episodes per year, accounting for 28% of all peritonitis episodes. We therefore perform quality improvement project, and we found that there are huge variation in PD center practices, lab capacity, and capabilities, particularly with respect to specimen collection and processing, which often deviated from the ISPD guideline recommendation. 3/4 of the labs provide microbiologic services only in working hour. Such the inoculated bottles would be stored at room temperature or even 4 degrees in fridge for more than 6 hours if the specimens are collected after hours. Refrigeration and freezing inoculated specimen may kill or retard the growth of some organisms. Less than 1/4 of the labs had complete equipment, reagents, and media to culture anaerobe molds and tuberculosis. Culture negative peritonitis is typically greater with the number of facility practices, including smaller facility, having no nephrologists, having smaller lab capacity, lacking standard operating procedure, and lacking local accreditation certificates. when pair PD sample were simultaneous culture, one in the local lab and the other in the central lab. Interestingly enough, central culture can improve culture negative yield by 28%, as shown in the graph, by picking up some Phacidian organisms, including fungi, tuberculosis, and streptococci. We are now launching a nationwide quality improving project. Let's shift gear to patient survival. From the PDOPPS result, Thailand seemed to have the worst patient survival compared to the other participating countries, with 83% and 54% patients survive in the first and 5 years of PD. When deeper exploration, we found that the death rate only high in the first 2 years. After that, the rate fall in the same range as the other countries in the third and fourth years. Using Thailand PDOPPS data, we estimate that the survival and the relative mortality hazard for PD patients according to a real-life PD initiation practices in Thailand to answer the question of high first-year death rate. The patients were categorized into 4 groups. One is PD only. The second is HD transfer to PD. Third is PD with HD transfer. Fourth is PD with initial temp HD, reflecting unplanned dialysis. PD with initial temp HD was associated with increased risk of death with adjusted hazard ratio of 1.56. Of note, PD with initial HD was significantly more frequent in patients with lower educational attainment, shorter ESKD vintage, and lower eGFR level at the beginning of dialysis. In conclusion, the policy shows that health financing is not the sole factor for achieving the policy goal. Thailand had highest incidence of pregnancy-related deaths and late referral, causing high unplanned dialysis, poor functional status, malnutrition, and unpleasant blood chemistries in the short term. An improvement in PD supporting system, including culture techniques and nutritional support, are urgently needed for sustainability of the policy, and all labs should receive proper accreditation. Finally, we have to choose the right person on PD and transfer the patient to HD in suitable time frames. Again, the beauty of PD is still its simplicity, flexibility, and availability. I gratefully acknowledge the substantial contributions of all stakeholders, health providers, professional association, academics, and the staff member and investigators from the center who work tirelessly by participating in Thailand PD First Policy, Thailand PDOPPS, and International PDOPPS. Also a special thanks to ISPD and ARBOR for allowing Thailand to learn and participate in the PDOPPS. And finally, I would love to take questions at the end of this session.
So thanks very much, Golf, for an excellent presentation, and I'm continually impressed by what you're achieving in Thailand. So we'll now have the third talk in the PDOPPS session, and that will be delivered by Jeff Pearl, and it's going to be an update on the OPPS study, which is around peritonitis prevention in the US.
The investigators in the peritoneal dialysis outcomes and practice patterns.
Oh, here we go.
And it's an honor to be a co-PI on the Optimizing Prevention of Peritonitis in the United States study, which is a sub-study of PDOPPS, along with my colleagues, Dr. Ron Pizzoni. Today, I'll be highlighting some findings from PDOPPS and OPPS with regards to lessons learned and it's an honor to be presenting at the Spring Update meeting. These are my disclosures, and I just want to start everything off with my philosophy on peritonitis and PD infections. The inferior nephrologist treats peritonitis, the mediocre nephrologist attends to impending peritonitis, and the superior nephrologist prevents peritonitis. So of course, prevention is really important, and I hope to share some key findings from all three of these particular domains. So what are 10 things we have learned about PD-related infections in PDOPPS and in OPUS? The first one, I think, is that we all need to speak the same language. And one of the main mandates of OPUS is to standardize the definition of peritonitis. And with my colleague, Dr. Muthana Al-Salawi, we did a systematic review of peritonitis definitions that were employed in observational studies and randomized control trials. And as you can see here, after a rigorous investigation of the studies in the literature, we looked at 77 studies, 3 of which were randomized control trials. Effluent cell count criteria was only present in 54%, which constitutes part of the ISPD definition that the cell count meet the criteria for peritonitis. Clinical features were only described in 45% of studies, and the demonstration of a positive fluid culture was only provided in 25% of studies. And overall, 29% didn't specify how peritonitis was defined. So in the PD community, we have an important role to play in terms of standardizing the definitions of peritonitis. And there are some challenges with the definitions. We have high rates of culture-negative peritonitis, and so the cell count alone might be important and sufficient for diagnosis. The ISPD target right now is less than 0.5 episodes per patient year of peritonitis, but over 3/4 of US facilities had lower peritonitis rates than this benchmark from our findings. So we may need to be even more aggressive and set lower targets for peritonitis. The time at risk calculation usually for peritonitis begins when the patient has the first treatment at home. But of course, patients are at risk for peritonitis from the time the catheter is inserted, and we need to account for those early peritonitis risks. And in patients who are hospitalized, oftentimes facilities do not report these peritonitis events because they occur as part of a hospitalization. And sometimes they get missed and they need to be captured in some capacity. How do we classify the organisms based on peritonitis classification? Some have done gram-positive versus gram-negative. Some have classified it as enteric versus non. We really need to be important. We really need to develop a standardized classification because that's important for outbreaks and root cause analyses. Some programs exclude peritonitis that occurs as part of a surgical issue, such as a bowel perforation. Some do include it. We need to make a consensus on that particular type of episode. And how do we define critical peritonitis outcomes? Death associated with peritonitis, catheter removal, and permanent transition to hemodialysis. So working with our OPUS sites, we're working towards standardizing and employing a definition for peritonitis. And it is our hope that we'll work in collaboration with the ISPD to update the 2022 guidelines accordingly. And we know that peritonitis is important to patients because, again, in our collaborations with the Standardizing Outcomes in Nephrology group, you can see here that PD infection by this group was listed as one of the key important outcomes to kidney care professionals and a multi-diverse group of stakeholders that included patients as well. And we did, in the spring, sit down and try to work on a standardized definition of peritonitis that looked at definitions that would be applicable in a diverse range of settings and to a diverse group of patients and care partners and stakeholders, and hopefully that consensus will be published shortly. So if you want to read more about our standardized definition and the considerations in developing that, this is a sort of white paper that the OPUS group put together looking at optimizing the definition of peritonitis that was published in CJSON and really outlines a blueprint for some of the challenges in working towards a standardized definition. This is work that we're currently doing, being led by Eric Young and Keith McCullough and Junhui Zhao at Arbor Research, trying to use CMS claims code in the United States to capture and identify peritonitis. And you can see here, there's a whole host of diverse coding that goes into the definition of peritonitis that we are working through to try and see if we can extract meaningful information from CMS claims to try and capture peritonitis, but it is not without its challenges. So in terms of our second point, uptake of evidence-based practices is quite variable. We know that topical application of antibiotic cream or ointment to the catheter exit site is a evidence-backed grade 1A guideline recommendation, as is prophylactic antibiotics to be administered before catheter insertion. When we look at the penetration of antibiotic prophylaxis at the time of catheter insertion, we can see that with the exception of Canada and the UK, there are some clinics that do not endorse using antibiotics at the time of catheter insertion, the US being only 63% of clinics in our study, which suggests we have a long way to go in terms of knowledge translation of best practices when it comes to infection prevention. What about exit site antimicrobial prophylaxis? Either mupirocin or an aminoglycoside is acceptable. In the US, most clinics are using an exit site aminoglycoside based on the randomized controlled trial evidence by Beth Pereno and Judy Pernodini. But you can see in countries like Japan and Thailand, they fall very much behind in terms of the use of exit site prophylactic antimicrobial prophylaxis. And this may relate to local policies that need to be reconsidered. So the third thing we've learned is that peritonitis incidence is more variable within countries than between countries. And this is our paper published in AJKD looking at peritonitis rates within the PDOPPS study. And you can see overall there are some country-to-country differences, but what you can see is there within a country significant variability in the rates from one center to the next. And one of the main foci of PDOPPS and OPUS will be to understand the drivers of that variability from a patient perspective, from a practice perspective, and from a facility characteristic perspective. Number 4, facility practices do impact peritonitis rates. And interestingly, when we looked at antibiotics at the use of catheter insertion, even though that was fairly well penetrated with the exception of the United States, you can see that clinics that said that they did not use antibiotics had a higher risk of peritonitis. And the counter here is that clinics that did say that they use prophylactic antibiotics tended to have a lower risk. Is it that practice or some of the other practices that go along with this that led to those facilities tending to have a lower risk of peritonitis is unclear. Also, interestingly, we saw the higher the use of APD by a facility, the lower the risk of peritonitis. And again, do other practices track along with using APD, or is APD itself, by virtue of less connections, protective against developing the risk of peritonitis? The fifth point here is that culture negative peritonitis is a major challenge. And again, the ISPD guidelines understand this and suggest that culture negative should be no more than 15% of all episodes. But we can see here that in some countries do reach this target, but some countries go well above that. And if you look at Thailand, for example, almost a third of episodes are culture negative, which highlights a major problem. What is the impact of culture negative? Well, this is work by Dr. Al-Salawi that was just recently accepted to AJKD that showed that having a culture negative peritonitis was associated with a higher rate of catheter loss, death, and transfer to hemodialysis, relapse or recurrent. So this is the cure rate, looking at the odds of a cure, which is the absence of those events. So not needing transfer to hemodialysis, not dying, not experience a relapse or recurrent event. And you can see here that culture negative is associated with a lower rate of cure compared to gram positive, which was the reference point. So culture negative does have implications in terms of being associated with worse peritonitis outcomes. And one of the things that one of our PDOPPS countries did is looked at a local quality improvement study where cultures were sent locally to a local lab, but also to a central lab, which employed ISPD guidelines for culture management. And what you can see here is where there was local no growth in 28% of samples, the central lab was able to grow an organism, which suggests to us that local practices in terms of culturing techniques can be improved. And when we employ a standardized way of culturing, which was done at the central lab, we can improve the yield of organisms and reduce the risk of culture negative peritonitis. And kudos to our Thai colleagues for embarking on this multi-center quality improvement project. Number 6, not everything can be studied via a randomized control trial. Simon Davies looked at hypokalemia and its risk of peritonitis. And even though a low potassium is associated with a higher risk of peritonitis, What we learned from this study is that low potassium does track with other malnutrition parameters, and certainly it may be a marker of a more malnourished, unwell patient. So we will never do a randomized trial looking at serum potassium replacement in peritonitis. We probably all would judiciously replace serum potassium, but this association is important as there is an association with lower potassium and a higher risk of peritonitis. Number 7, peritonitis is the most common cause of transfer to hemodialysis globally. If we look at PDOPPS data, no matter what country we look at, the leading cause of transfer to hemodialysis is peritonitis, which suggests that an important area to work on, and it might be modifiable to improve time on therapy, is to develop strategies to both prevent peritonitis in the first place and treat the morbidity of peritonitis and improve peritonitis outcomes. And this is something that is applicable to all of our PDOPPS countries. And when we look at peritonitis outcomes, when we look at death, transfer to hemodialysis, catheter removal, relapse or recurrent, with the exception of a higher rate of death in Thailand following peritonitis, we can see that across most countries, the distribution of these events is fairly similar. In the UK, however, there is a higher rate of catheter removal following peritonitis, but this is, peritonitis outcomes are poor and are fairly similar across countries with some of the differences that I highlighted. And if we look at the likelihood of cure rate by country, again, cure here is defined as absence of death, catheter removal, transfer to hemodialysis, or a relapse or recurrence, we can see here that the cure rates are fairly consistent across countries, and again, are still quite poor. We need to improve the likelihood of cure following peritonitis. So number 9, empiric use of non-cephalosporin-based treatment as empiric gram-negative peritonitis treatment may improve peritonitis outcomes. This was an interesting finding, and we looked at gram-negative peritonitis and looked at it by clinics that used a third-generation cephalosporin as first-line, aminoglycoside as first-line therapy, and Cipro. And some clinics may be anxious to use an aminoglycoside because of nephro or ototoxicity. On the other hand, there's emerging resistance to third-generation cephalosporins with ESBL and spice organisms. But what we found was your likelihood of cure was much higher in centers that used non-third-generation cephalosporin-based empiric therapy, either aminoglycoside or Cipro, which suggests that with emerging antimicrobial resistance, we may need to reevaluate our policies across clinics and consider aminoglycosides and ciprofloxacin as first-line therapy over ceftazidime. Now, this is observational data. It really needs to be borne out locally. You should be reviewing the microbiology of peritonitis in your clinics in making these decisions and policies, but this would suggest that a reevaluation of empiric therapy may be warranted across a host of clinics participating in PDOPPS. And last but not least, when it comes to reducing peritonitis and improving peritonitis outcomes, think globally and act locally. It's our hope that PDOPPS and OPUS are global studies that will help shed light on important factors to reduce the incidence of peritonitis and reduce the morbidity associated with peritonitis. But we need to act locally. As the Thai Quality Improvement Project showed us on reducing risks of culture-negative peritonitis, and as the last slide I showed you on different antibiotic combinations, heralding the need to look at antimicrobial resistance patterns locally, this is global data, but really begs us and asks us to look locally and develop local strategies to reduce the risk of peritonitis. So I hope I've provided some initial insights from PDOPPS and OPUS on infection prevention when it comes to PD. And I know this was a little bit of a whirlwind tour, but would be happy to have some discussion now and take any questions that you may have. And thank you so much for your time.
Okay, we're a bit short on time, I think, Bruce. Is that not right?
Well, yeah, Simon, we could take 3 minutes or so.
Yes, but if I can have Mark and Golf up. Is Mark still there? Yes, Mark. Okay, I've got to go quickly with this because there is short time. I'm going to wrap up a couple of things in one question. The first point I really wanted to get you to see if I'm right in saying this is that the research you presented really tells us that we can't equate time on therapy with outcomes, actually. That there are PD is being used in different ways. So I'd like you to comment on that, and then as a subtext to that also just address the issue as to whether what you think the effect of the MDT is in that setting.
Thank you. So yes, I mean, I think that's the key finding actually, is that the time on therapy, because it was coming out as so low in places like the UK, where we've had a significant and sustained decline in PD, I think that what this data suggests is that a lot of that will reflect transplantation rates in the UK, whereas obviously it's a very different picture in Thailand and Japan, where you don't have anything like the same rate of transplantation. So I think that needs to be borne in mind when we think about using prevalence of PD as a marker of how much PD activity there is in the country, because it suggests that in the UK we're probably actually have quite a high rate of using PD, but we don't keep them on for very long because we've got a high rate of transplantation, which actually sounds quite good. So it's just being mindful of the way the different modalities are used in the different countries when trying to interpret your overall usage of PD and the impact of that on prevalence. In terms of the multidisciplinary team, I mean, I think it just demonstrates the clear benefit of having multiple members involved in the team. I mean, certainly locally, we find that the nurses are extremely useful and a really important part of the team, and having their expertise in working out what's going on with the patient. I mean, we can probably do with trying to tease out a little bit exactly how some of these things impact on transfers to HD, because we've analysed hemodialysis transfer as one single overall outcome, but obviously there are many different reasons why patients switch, and something that improves, say, peritonitis as a cause is not going to have an impact on say psychosocial reasons for switching. So I think we could do with teasing out the exact causes that these different risk factors are impacting on, but I think it's just a sort of headline measure that it really does matter to have your multidisciplinary team involved in looking after your patient in regular reviews.
Thanks, Mark. I think that's a really good way of describing the findings of the study, I think. Golf, we're going to move across to you now with rather limited time again. I mean, I think first of all, I just want to continue to congratulate the group on what they achieve. The outcomes are really very good when you consider the pressures that you're under, and also that the socioeconomic group that get PD is perhaps, you know, a less well-off, less well-educated group of patients. So this leads me into my question, which is around about this issue of culture-negative peritonitis. I think there is a question about that, and I think really what they're getting at is how much of this could be a reflection of facilities within a centre, for example, in the ability to grow the organisms, versus the real challenge of educating and serving a population that is really quite compared to Western countries, I'm talking relatively disadvantaged in terms of their, for example, their own self-knowledge about infection. So perhaps you could just answer me a bit about why it is that the culture-negative issue is so important.
Well, this question is I think first of all, I have to thank for your question, but it's difficult for me to answer because I have to project for the global. Actually, from central culture, I can pick up a quite faceted organism. The most common is fungus, and second is tuberculosis, and the other one is a streptococcal. I think streptococcal is quite common than we thought, because it comes from dental problem. And normally, if you not perform bedside culture and short transfer to the laboratory and incubate them into the 37 degrees, sometimes the streptococcal will die or not culture. So maybe I anticipate that for the global, you can pick up more streptococcus. In my facility, we can pick up from 2 to 3% to 10 or 12%. So you can increase at least 10% of the culture negative by pick up streptococcus.
Okay, so what you're saying is it's a different mix of organisms is also a problem,
right?
And that different mix often is more challenging to culture in the first place. So that's very interesting, and I guess there's a huge opportunity here to change things and change practice and improve on outcomes. I think probably Bruce, I don't know what do you think about timing? Well, I know that we're a bit tight for time.
Yeah.
We've got several messages.
I think we are tight. Yeah, indeed. I think we should move on. But Simon, feel free, please, to answer questions by the chat, by the Q&A chat function,
yes,
and/or Simon others. And if the audience can please feel free to continue to send questions our way, that would be great. Simon, thank you so much for your leadership generally in the PD community and for PDOPS specifically, as well as to our excellent speakers. Thank you very much. We're going to pivot on now quickly to our last section, which is our study of CK-DOPPS or advanced CKD. This will be moderated by Roberto Fijo, Senior Research Scientist at Arbor Research and Professor at the University of Curitiba in Brazil. I will, just a quick program note to be sure that we end the full symposium on time, which is at the top of the hour in 45 minutes. We won't have a dedicated section for broad research ideas. However, what we will do is during the next 45 minutes, pass on some of the questions to you all through the Q&A function along with answers. We certainly encourage any other ideas that you might have as well. With that, on to Roberto. Thank you.
Thanks, Bruce. And we'll now turn into the series of 3 presentations based on our moderate to severe CKD study, or CK-DOPPS. CK-DOPPS follows the conceptual design of the DOPPS study, but focuses on the important transition period from the non-dialysis to dialysis phases, which tends to be not so well captured in other observational studies in the CKD population. CK-DOPPS started recruiting patients in 2014 and currently includes approximately 11,000 patients from 5 countries: Brazil, France, Germany, Japan, and the USA. I would like to echo Bruce in thanking all investigators, study coordinators, participating patients, and study sponsors. Also, I would like to thank in particular the fruitful collaboration that we have with our study partners, CKD in France, the DN network of Germany kidney centers, and the REACH-J study in Japan. So this is a very brief description of studies that we are doing with different partners. And with no further ado, I wanted to just move to the first presentation that will be given by Murilo Guedes, a physician from Brazil, who spent a year with us in Ann Arbor as part of his PhD studies, and was very productive, had a very productive time, focused on the studies, including the one that we're going to hear today about iron deficiency and outcomes in patients with CKD. So let's hear Murilo's presentation now.
Hello, everybody. Thank you for being here. Thanks, Arbor Research, for inviting me to be speaking on behalf of this great group of collaborators. Such a pleasure to be presenting our results on serum biomarkers of iron stores in cardiovascular and all-cause mortality outcomes in non-dialysis CKD patients in CK-DOPPS. This work has been recently accepted to be published in JASN. I'll be covering key results here in the short presentation. Full results should be out soon. Well, in terms of background, the most important concept we have to keep in mind is that iron is fundamental for many biological functions other than hematopoietic pathways. In fact, iron is important for energetic metabolism pathways in mitochondrial and non-mitochondrial function. This may have important clinical implications, as we're going to be talking in the next few slides. Iron deficiency in non-dialysis CKD patients has an important burden in terms of prevalence. So as we can see in this previous CK-DOPPS work led by Michelle Wong, across different CKD stages, up to 1/3 of individuals we have iron deficiency as defined by T-cell load in 20%, And even among individuals without anemia, up to 1/3 of those individuals as well will have iron deficiency. In terms of management in non-dialysis CKD patients, KDIGO guidelines state that iron deficiency screening and therapy should be considered only among individuals with CKD anemia, particularly those who are suited to be started on ESA therapy. There's no evidence that reestablishing iron stores improves clinical and patient-reported outcomes. And in fact, this is a result of the fact that there is no well-designed, robust phase 3 randomized controlled trial assessing the impact of correction of iron deficiency on clinical outcomes and also patient-reported outcomes. Most of trials have focused on surrogate outcomes, including hemoglobin achievement and ESA doses, rather than focusing on important and robust clinical outcomes in non-dialysis CKD patients. But this is not true for other populations that share similar pathogenesis of iron deficiency as non-dialysis CKD patients. In heart failure, for instance, previous randomized controlled trials have shown that treatment with IV iron improves that and heart failure hospitalization events, as shown and suggested in this meta-analysis. More recently, publication in Lancet of the AFFIRM trial that enrolled individuals with acute heart failure who also had iron deficiency at enrollment after a clinical stabilization in the hospital were randomized in 1-to-1 to receive 24 weeks of IV iron treatment versus placebo. In such a study, patients with heart failure had in fact reduced incidence of heart failure hospitalizations over time in the group of individuals who were randomized to IV iron treatment, which suggests that iron treatment has an important impact in terms of heart function in those individuals, reducing acute heart failure events over time. In nephrology, as you are all very well familiar with, in end-stage renal disease more recently, the pivotal study has shown that proactive high-dose iron treatment in these dialysis patients improves cardiovascular events, reducing the incidence of MACE events over time. And this also suggests that there is an impact of iron deficiency treatment on cardiovascular outcomes that may not be mediated by hemoglobin. This is our visual abstract for JASON. We designed the study to assess the impact of serum biomarkers of iron stores on all-cause mortality and cardiovascular events in non-dialysis CKD individuals. Our main goal was to trigger and to establish a discussion that may potentially yield a randomized controlled trial in this area that may actually assess the real impact of treatment of iron deficiency on such outcomes in non-dialysis CKD patients. So we use the CK-DOPPS cohort, as you're all well familiar with. So those are CKD patients varying from stage 3B to 5 non-dialysis from different countries in the world. In terms of study design, our exposure variables were TSAT and ferritin at study entry. So we assessed TSAT and ferritin at study entry, along with hemoglobin at the same time. So we captured hemoglobin at the same time as those exposure variables. And also our inclusion criteria were availability of outcome variables, including all-cause mortality. Our primary outcome was, in fact, pre-ESRD all-cause mortality, and secondary outcomes were the MACE. The MACE we define as cardiovascular death, non-fatal MI, non-fatal stroke, and heart failure hospitalization. Our population included 5,145 non-dialysis CKD patients from France, Germany, Brazil, and the US. Majority of patients were from France and Germany. As I said, we captured hemoglobin at the same time as TSAT and ferritin because we wanted to adjust for hemoglobin in the model. So as you can see in the diagram there, we are adjusting for many confounders of the association between iron stores and outcomes, and hemoglobin is a potential mediator of such association because we know that hemoglobin is associated with worse outcomes. So we wanted to ensure that hemoglobin was captured at the same time to build models, including and not including hemoglobin. And also we ran subgroup analysis by hemoglobin at baseline to assess the potential effect modification of anemia on those associations. In terms of sample characteristics, for time's sake, I'll be presenting only the TSAT results. This is the table 1 stratified by TSAT. So majority of individuals we have TSAT between 25 and 35. And as we know from the literature, patients with lower TSAT tend to be older, a greater proportion of female patients, and a greater proportion of comorbidities, including cardiovascular comorbidities as well. ESA therapy is more common both at the lower and upper end of TSAT, and iron treatment in general is more common at the lower end of TSAT. Majority of individuals here receiving oral iron. Naturally, hemoglobin is lower in the lower TSAT group, and eGFR varies slightly between categories. When we look at the all-cause mortality, these are all-cause pre-SID all-cause mortality events. Our reference group is the 25 to 35% TSAT group, which composes the majority of our sample size. Each one of the circles there, they depict a different model. So for 1 to 5, we get more progressively adjusted models. 1 unadjusted, 2 to 4 include different confounders varying from comorbidities, demographics, and inflammatory variables. And model 5 includes hemoglobin, which is a potential mediator variable, as I just said. As we tend to see, in patients with TSAT lower than 25%, there is a progressive increase in risk of all pre-SRD all-cause mortality, with hazard ratios up to 1.5. In fact, this association tends to be linear for this lower end of TSAT. Individuals with 35 to 45%, tended to have lower risks for all-cause mortality, and all those results are robust even after adjustment for confounders and hemoglobin. And also, we found no interaction between hemoglobin and this association. This figure here depicts the interaction between TSAT and ferritin and all-cause mortality. As we tend to see in the x-axis, the TSAT, and the y-axis, the ferritin. In the center here, we have a reference for TSAT of 25 and ferritin 130. As we tend to see on the scale, the red regions are the higher hazard ratios, and the green regions, the lower hazard ratios. And as we move from the left into the upper part of this graph here, we tend to see that there is a higher risk of all-cause mortality, which suggests an interaction between those variables. In fact, individuals with lower TSAT and higher ferritin were at the highest risks in this cohort here, in this study. In terms of major adverse cardiovascular events, as we defined, we tend to see pretty similar and robust results. So individuals, as compared to the reference at 25 to 35%, individuals with lower TSAT tended to linearly have progressively higher hazard ratios for MACE events. These results are up to 2-fold increased risk of MACE in this population, even after adjustment for confounders. Even after adjustment for hemoglobin, these results are true, and that there was no effect modification by hemoglobin as well. Finally, this is our visual abstract that we presented at the Kidney Week. This just summarizes our key results, and we're just going to be presenting the next few slides. So in patients with non-dialysis CKD with or without anemia, lower TSAT levels are associated with higher risk of all-cause mortality and MACE. All these results, they suggest that we definitely need well-designed randomized controlled trials to evaluate the impact of iron deficiency treatment on clinical outcomes in non-dialysis CKD patients. Thank you very much.
Thanks, Murilo. We'll get back to you in our Q&A session at the end. So our next presenter is Natalia Lecarpino, who's a postdoctoral fellow at the Renal and Cardiovascular Epidemiology team at INSERM in France. Natalia's been working on an interesting project trying to understand the international variation in the incidence of kidney failure. She will be presenting on this during the year at DTA in a couple of weeks from now. And today she's going to be presenting to this group some of the preliminary results of that project. So let's watch Natalia's presentation.
Hi, my name is Natalia. I'm an epidemiologist and postdoctoral fellow at the CKD Hunt team, and I'll be talking about international variation in the incidence of kidney failure in the CKDOPPS study. Data from national registries of kidney replacement therapy suggest large international variation in kidney failure incidence, as we can see in this world map from the USRDS Annual Report 2018. However, this data provide us with a partial picture of kidney failure burden worldwide, as 50 to 75% of individuals needing kidney replacement therapy do not benefit from it. Also, variations in practices of kidney replacement therapy referral and in conservative management may impact the rates of kidney replacement therapy initiation independently of kidney failure incidence. Additional information on the onset of low eGFR, as well as on patient characteristics affecting kidney failure risk, may increase comparability of kidney failure burden across countries. Our study aim was to assess whether the incidence of kidney failure varies by country after accounting for well-known risk factors, including sequentially age, gender, race, baseline eGFR, albuminuria, BMI, diabetes, cardiovascular comorbidities, malignancy, systolic blood pressure, and RAS inhibitor prescription. We included patients with moderate to severe CKD under nephrology care enrolled in CKDOPPS. Recruitment was done from national samples of nephrology clinics in Brazil, France, Germany, and US from 2012 to 2017. For this analysis, we excluded patients with eGFR less than 15 at baseline, leaving us with more than 7,000 patients. Our outcome, kidney failure, was defined by either kidney replacement therapy initiation or sustained eGFR less than 15. Here, we did not include the criterion of death for renal causes because of difficulties in assessing it in the cohort. Note that eGFR criterion is dependent on eGFR assessment, as we will only see eGFR less than 15 in patients with measured eGFR. In the histograms below, we have the number of eGFR assessments in the x-axis and the percentage of patients in the y-axis by country. These histograms show that the frequency of eGFR assessment varied importantly. Of course, the duration of follow-up is something to take into account. It ranged from 26 months in the US to 55 months in Germany, but this variation does not explain everything. Remember that CKDOPPS is based on real-life practices, so the frequency of eGFR assessment will likely depend on services availability, on nephrologists' practices, and importantly, on CKD severity, as we will assess eGFR more frequently in patients at higher risk of CKD progression. For statistical analysis, we used variable proportional hazard models to estimate adjusted hazard ratios of kidney replacement therapy initiation. And we used a particular model, the UNAS-DES model for interval sensor data, to estimate adjusted hazard ratio of sustained eGFR less than 15 and the probabilities of kidney failure. This model is a three-state model in which patients with CKD stage 3 to 4 are at risk of progressing to either eGFR less than 15 or kidney replacement therapy initiation. eGFR less than 15 is a transient state, so patients can start kidney replacement therapy after meeting this event. Kidney replacement therapy initiation is the absorbing state. With this model, we can take into account the uncertainty in the time to eGFR less than 15 for patients for whom the event was observed. We can also take into account the uncertainty in the onset of eGFR less than 15 for patients who met the end of follow-up without eGFR measurements below below 15. Here are our results. Patients' characteristics differed across CKDOPS countries. Median age was the highest in Germany, 75, and the lowest in Brazil, 67. France included more men than the other countries. Brazil and the US included more Black patients than the other countries. The frequency of diabetes was the highest in the United States, 55%, and the lowest in France, 44%. But the most important, there was large variation in the CKD stage at baseline. Note that France included much more patients with CKD stage 3A to 3B than the other countries. Here are event numbers. We already discussed about median follow-up. Crude incidence of kidney replacement therapy initiation per 100 patient year at 2 years of follow-up was the highest in Germany, 5.6, the lowest in France, 2.6. And that for deaths before kidney replacement therapy initiation was the highest in Germany and the United States, 3.1, and the lowest in Brazil, 1.3. Note that I do not report incidence of sustained eGFR less than 15 here, because of the uncertainty in the time and the onset of this event. Here we have hazard ratios of kidney replacement therapy initiation across countries. The reference was the United States. In blue, we have hazard ratios with confidence intervals below 1. In red, hazard ratios with confidence intervals above 1. In the crude model, we had significant lower risk of kidney replacement therapy initiation in Brazil and in France compared with the United States, and higher risk in Germany. When we adjust for baseline eGFR and demographics, this difference disappears for France and Germany, and further adjustments in the final model, we have a significant 40% lower risk of kidney replacement therapy initiation in Brazil, and a 40% higher risk in Germany as compared with the United States. Note that including systolic blood pressure and RAS inhibitor prescription virtually did not change estimates. With regard to sustained eGFR less than 15, the only significant difference compared with the United States was for France in the crude model with lower risk, but it disappeared with adjustment for baseline eGFR and demographics. Further adjustments had more modest impact in estimates. Finally, we have estimated probabilities of kidney failure, kidney replacement therapy initiation, and sustained eGFR less than 15. These estimations are adjusted for age, gender, race, and baseline eGFR. Thus, they refer to a given profile. Here, a white man, age 60 to 69, baseline eGFR 27, which was the median across the cohorts. The probability of kidney failure after 2 years from study enrollment ranged from 13% in Brazil to 16% in Germany. To conclude, variation in the incidence of kidney failure was more modest than that the incidence of kidney replacement therapy initiation in patients under nephrology care across CKDOPS countries. Overall, patients in Brazil seemed at the lowest risk of kidney failure, followed by those in France, the United States, and Germany. Assessment of real-life effect of therapies and exposures on CKD progression to kidney failure, especially by the means of international comparisons as performed by CKDOPS, are likely to be biased if we ignore non-dialyzed nor transplanted kidney failure. Besides, when analyzing the onset of low eGFR in real life, practice of eGFR monitoring may also impact the results. Thank you for your attention.
Well, thanks very much, Natalia. And we'll move to the last presentation that will be given by Elodie Spire. She's a PhD in public health and epidemiology at the clinical epidemiology team at CESP INSERM in France. And Elodie is going to be talking about the symptom burden and its impact on quality of life. Let's watch her presentation.
Good morning, everyone. Thanks to the DOPPS program for giving me the opportunity to discuss about the symptom burden experienced by CKD patients and its impact on their quality of life. Why being able to recognize and manage symptoms in CKD remains suboptimal? Firstly, because research in patients with CKD has tended to focus on those on dialysis only. Also, prior studies suggest that nephrology providers may not be aware of the symptoms that their patients have, including those that patients describe as severe. And consequently, many of them remain undertreated. Given the documented association between symptom burden and patient-reported outcomes or clinical outcomes, there may be a substantial opportunity to improve quality of life and other outcomes through better symptom prevention and management. From a clinical point of view, it could be expected that symptoms increase while kidney function deteriorates in patients with CKD. However, evidence for this association is lacking or contradictory, and large-scale studies of symptom burden in real-world non-dialysis CKD patients are still scarce, with high heterogeneity between studies. That's why in that context, we had three objectives. The first one was to describe the prevalence of reported symptoms in moderate to advanced CKD in DOPPS, stratified by country, gender, and eGFR, to describe association of patient characteristic with the likelihood of having high symptom burden, and also the first one, to investigate association of a symptom burden score with patient quality of life. To answer to this objective, we use data from 3 countries out of the 5 participating countries in the CKDOPS. Especially, we use data from a patient questionnaire which was administered in the US, in France, and in Brazil. There was no PQ administration in Germany at all, and data from Japan were not available at that time. Then, more than 4,700 patients had completed a PQ at baseline. And within this patient questionnaire, we used the KDQOL instrument, where patients were asked to indicate to extent to which they were bothered by each of the 13 following symptoms, which are muscle or skin related symptoms, cardiopulmonary symptoms, and 2 other symptoms about sex life and personal appearance. Responses to individual items on the KDQOL survey were used to calculate score on several subscales according to recommendations specified by the developer of the instrument, of course. And then we were able to calculate 3 scores for 3 dimensions, one specific on symptom and problem of kidney disease, and 2 for the mental and physical component summary scores as well. Each score varies from 0 to 100. Higher score indicates a better quality of life or lower symptoms problem. Now, I will show you the prevalence of being very much to extremely bothered by each symptom. In this figure, we see that more than 20% of patients overall are reported to be very much to extremely bothered by soreness in muscle or washout or drains. But the following symptoms, nearly 15% of patients reported to be bothered as well, till 2% reported some chest pain. And if you are looking at the differences of prevalence of these symptoms between countries, we see that patients from Brazil reported less symptoms than patients from the two other countries for dry skin, sex life, and shortness of breath. It was the opposite way for two other items, which are nausea and lack of appetite. I would like to talk a little bit about these 4 symptoms because when we started this analysis, we noticed some translation issues for these specific items in the Brazilian version. And so that's why there is no data from Brazil here. It's not because they doesn't have those symptoms. It's just because we weren't able to show the prevalence. But don't worry, it doesn't impact on the calculation of the subsequent scale, the score of the scale. And now, if we look at the difference between men and women, we observe that women reported significantly more symptoms than men, and for each symptom, it's the case. But in fact, only one item doesn't follow that rule. And indeed, as you can see, 23% of men have reported to be bothered by their sex life as compared to only 7% of women. And in regards to the prevalence of symptoms by CKD stage, we show that symptoms appear even at early stage. And also some symptoms increase with the progression of CKD, as it's shown in red right now. But when we adjust for several characteristics, demographics, or medical history, this association remains for only 3 symptoms: the cramps, washout or drain, and lack of appetite. As I said earlier, we were able to calculate a score for the specific subscale symptom problem. And overall, the mean score of that subscale was 77 points. And from this score, we decided to categorize patients into 3 groups according to the score's tertile. And now we can say that patients have a low, an intermediate, or high symptom burden. And as you can see, 25% of patients experience a high symptom burden, which is important. And this is this category that we are looking at in the next slides. Indeed, after performing multivariate regression analysis, we saw that living in France, female gender, and having some comorbidities were more likely to experience high symptom burden. Finally, we performed mixed linear regression to describe association between PCS and MCS scores, with each burden symptoms category presented earlier. And as shown in this figure, as the symptom burden increased, patients displayed progressively lower PCS scores. And patients with a high burden at PCS score were near of 14 points lower than patients with a low burden in the fully adjusted model. The same conclusion can be done for the MCS score, even though it is less marked. Note that prior studies have indicated a 3 to 5 point difference in those scores to be a minimal clinically significant difference, which is clearly the case here. So to summarize our results, we can say that the most reported symptoms were soreness in muscle, washed out or drained, cramps, and shortness of breath. And it was shown even at very early CKD stage 3A. We also show showed that women reported significantly more symptoms than men, excepted for sex life. Then the burden of some symptoms appeared to increase with CKD stage, even after adjustment. Then 1 out of 4 patients has reported a high symptom burden, higher in France, higher in women, and also progressively poorer mental and physical health with increasing symptom burden, even after adjustment for numerous patient characteristics. So these results show that it's important to know how commonly these symptoms are experienced by non-dialysis CKD patients, and it's helpful both for care providers and patients in understanding how CKD can impact a patient life and supporting patients when they experience these symptoms. I thank you for your attention.
Thanks very much, Elodie, and I invite now the panelists to come up with their cameras for a live discussion. We have a few minutes. Great presentations, guys, and very nice to hear, some of these highlights of the CK-DOPPS research. We do have several questions from the audience, and I'll start with one to Murilo. It relates to the, to the relationship between ferritin specifically and clinical outcomes. And one question we have here is about, if you could really identify a specific threshold for ferritin that things start to change in terms of the relationship with poor outcomes at a higher level.
Well, thank you for the question. Thanks for the opportunity to be here discussing such an interesting, all interesting studies. So yeah, we definitely did not take a look at different thresholds at which the mortality may change across those variables. What we found was that patients with ferritin greater than 300 nanograms per ml tended to have higher mortality, hazard ratio 1.21. This is for pre-SRD all-cause mortality. While for MACE, we did not find any difference in terms of worse outcomes. These results could be potentially confounded by residual inflammation. That's important to state. We are not evaluating treatment here. We're just looking at varying levels of ferritin in TSAT.
Thanks very much, Murilo. Moving to you, Elodie, there's a question about the potential impact of symptoms on dialysis initiation. Do you feel that looking at this, that this might be something to incorporate in future analysis or perhaps in, clinical practice, that you, start looking at the symptom burden as, a way of sort of understanding dialysis initiation, or perhaps even dialysis, just postponing dialysis initiation in terms of management of symptoms?
I think it's completely possible to do that and very soon, or much sooner than later. Also, we will be able to answer to that question because we follow patients even after starting dialysis or being on transplantation. And for sure, as we can see, patients have a very high symptom burden and in early stage of CKD. So the sooner is the better. And I'm sure there is a lot to do to decrease this burden for patients, and also to recognize that patients with CKD, even at moderate stage, have a lot of symptoms. Yeah, for sure.
Yeah, I think this is, it has a monitoring symptoms will have an increasing impact on practice. I'm just speaking here as a clinician, I think as we understand better symptoms and particularly develop ways of managing it, I think that we might change this important phase and decisions around the dialysis initiation. I think we've seen already since the IDEAL study that looked at two different initiation thresholds for using GFR, that there is a tendency to value less the number GFR and more how people are feeling. And I think, you know, your work adds a lot of value to understand the burden itself, and perhaps might be something that might generate a real recommendation when to start dialysis, and at what dialysis start threshold we will be seeing the best clinical outcomes for patients in the long term. So I think this is really an area that's very important and has a lot of applications in clinic. Now talking about dialysis initiation, Natalia, thanks for sharing in the chat the average GFR values for different countries. Quite interesting, right? Because there seems to be a variation in the GFR level that in average patients are being transferred into dialysis in different countries. Can you expand a little bit on that? I mean, how do you see those differences and potential reasons for that?
Thank you, Roberto, for the question and the audience. Actually, it's a little bit difficult to interpret this data because of missing data according with country. So the most reported data was for France and Germany. About 2/3 of patients had information within less than 30 days before kidney replacement therapy initiation. So they had GFR of 9 and 10. And for Brazil, for example, it was quite surprising that they had the most elevated median GFR at KRT initiation, 15. So must acknowledge that about 2/3 of patients did not have information on eGFR at this moment, and these patients had much more heart failure than the others. They had the threefold more heart failure than the others from the other countries. So it's a little bit difficult to interpret, but it goes in a way that the timing of KRT initiation does not explain our results.
Yep, that's right. Murilo, back to you. So we heard in some discussion in the chat and also in Bruce's presentation some of the impact of the understanding of iron replacement in outcomes in the dialysis population. We're talking about the pivotal study that showed increase in outcomes when a more liberal iron treatment strategy was actually applied, and this was done in Europe. It's a different situation in the US. But looking at your results in terms of the relationship between iron markers of iron stores, if they can be, I mean, I know that they are not ideal in and outcomes in the CKD populations. Do you see something like a high level message that we could bring from pivotal and the observational studies that you carried?
Certainly. I think not only from pivotal, but we definitely need to learn a lot from the heart failure literature as well. But we have to remember that in terms of pathogenesis, that iron deficiency varies a lot when we transition from the non-dialysis CKD to the dialysis world, particularly because functional iron deficiency is much bigger in terms of incidence for dialysis patients, particularly because of ESA use, extensive ESA use, and also because the iron demand is greater. But even so, I think the pivotal has a very strong message that we have to push forward from the non-dialysis CKD field, along with the result from the heart failure trials. In terms of pathogenesis as well, as I stated in the presentation, there is a lot of similarities between heart failure and non-dialysis CKD individuals. And in terms of potential clinical trials as a path forward, we definitely need to take a look at those heart failure trials in terms of design and outcomes to yield better evaluation of such interventions.
Well, thanks, Murilo. Thanks, Elodie and Natalia. It was great to see you guys. So nice to see, young faces of promising researchers in the CK DOPPS part of the symposium. Thanks very much, and appreciate that.
Thank
so
you
with that,
you.
I'll just transition back to Bruce Robinson, who would be providing some final comments and closing remarks. Bruce, are you there?
Yeah, indeed. Right. Roberto, thank you very much. And thank you to the speakers as well. Really interesting discussion. And just as noted before, it's just wonderful for us to have some junior to mid-level folks join with us and work with us. We're just so happy to help with career development, as we have so much to do and more than we can do alone here. So please encouraging folks to reach out for opportunities. We had a ton of research ideas that came forward, many of which were shared back by the chat Q&A function, and look forward to following up with you further offline. Please remember to reach out to us with other questions, dops@arborresearch.org. Follow us on Twitter @DOPPSstudy as well. And then if we just move just to the final slide, which is showing the balloons once again. Just want to note again, we're just so appreciative of being able to celebrate our 25th year of the DOPPS program along with you, and extending a heartfelt thanks to everybody. And indeed, we look forward to future work together with you to help continue to improve the lives of kidney patients. With that, we're actually right on time, and we'll call an end to today's session. The presentation will be uploaded shortly on our website as well, so folks are very welcome to download after this session ends. Thank you all. Thank you all for your attendance, and thanks again to the panelists and speakers. Thanks and good day.